Hello, everyone. My name is Kirsten Walsworth, and I am here today to present a case about a patient who came to our clinic with nonspecific symptoms that led to a very suspicious clinical picture. So, she came into our clinic after reporting generalized abdominal pain and bloating for approximately 1 month. However, prior to this, she was overall a very healthy woman. Paracentesis was performed a week prior to coming to clinic, and they removed approximately 4 liters of cloudy fluid. Review of systems, she denies early satiety, vaginal bleeding or abnormal discharge, hematuria, hematochezia, nausea, vomiting, diarrhea, constipation, changes in bowel or urinary patterns, fever, chills, dyspnea, chest pain, and unexpected weight changes. On review of her histories, she has a past medical history of multiple ovarian cysts as well as anxiety and depression. And for her surgical history, she had her right ovarian cyst aspirated in 2006 and ultimately had a right-sided oophorectomy because of recurrent cysts in 2008. Her family history is notable for breast cancer and her paternal grandmother. However, no genetic testing was done at that time. Obstetrically, she is G3P3, and gynecologically, her last menstrual period was 1 month prior to arrival in clinic. She reports menses every month without significant pain or bleeding. She has no history of abnormal pap smears, no history of abnormal mammograms, and she denies any history of STIs. On physical exam, her vitals were within normal limits, and she had an unremarkable exam in all body systems except for GI and gynecologic. So her GI exam did show mild abdominal distension. However, the belly was soft, she was non-tender, and there were normal bowel sounds. On a gynecologic exam, she had normal external genitalia, and on bimanual examination of her pelvis, there was a palpable mobile mass identified in the left adnexa. The uterus was mobile, and there was a normal digital rectal exam. On speculum exam, her cervix appeared normal. Labs, she had an elevated CA-125 and CA-19-9. She did have a cytology report from the paracentesis, and the peritoneal fluid was positive for, quote, abnormal cells. Additionally, she did receive some imaging at the outside hospital. However, we could not view this in our EMR, and she did not have access to those when she presented to clinic. On our list of differential diagnoses, unfortunately, at the top is a gynecologic primary malignancy, most specifically ovarian cancer. Our team was less concerned about something such as endometrial cancer or cervical cancer, given that she was not having any vaginal bleeding and her physical exam had a normal cervix. There was also always the consideration of a metastatic malignancy, such as a GI primary, colorectal primary, or breast primary. However, she was not complaining of any breast concerns and was not presenting with the kinds of bulk obstruction symptoms we would expect from colorectal primary cancer. We also considered benign adnexal masses, particularly in the setting of her history of ovarian cysts. And lastly, we considered conditions such as hydrosalpinx, retroperitoneal sarcoma. Unfortunately, we had a strong clinical suspicion for ovarian cancer, so we decided to proceed with surgical staging, as this is the gold standard for staging presumed ovarian cancer. In spite of not being able to view the imaging from the outside hospital, we still proceeded with the surgery, and so we scheduled her for 1 week later for an exploratory laparotomy for staging and possible tumor debulking. The decision was made intraoperatively to perform tumor debulking, and optimal debulking was achieved with an exploratory laparotomy, total abdominal hysterectomy, and bilateral salpingectomy, as well as removal of mucinous ovarian mass, left-sided oophorectomy, infracolic omentectomy, sentinel lymph node dissection, and appendectomy. A colonoscopy was performed intraoperatively, and it was without lesion, and overall was a normal colonoscopy. We also performed argon beam ablation, and it should be noted that 4.5 liters of ascites were removed throughout the course of this operation, and her abdomen was filled with this thick, white, cream cheese appearing clumps of cells that were floating around the abdomen and the pelvis. Pathology was positive for low-grade mucinous carcinoma with expansile and confluent invasion pattern. The outer surface of the ovary is negative for involvement by carcinoma. There was no metastatic disease found in any of the 3 lymph nodes biopsied, and all nearby structures were negative for concerns of carcinoma. So, our final diagnosis was FIGO stage 2C3A mucinous ovarian cancer. It's worth noting that stage 2C is technically a surgical stage. It's not one that you'll see traditionally in textbooks. So our team went with this presumptive diagnosis because the patient did have cancer in one ovary without spread to nearby lymph nodes, and no signs of metastasis, which is characteristic of stage 2 ovarian cancer. That being said, the peritoneal fluid analysis at the outside hospital was positive for abnormal cells, and so it was impossible to rule out the possibility that those were in fact cancerous cells, indicating spread to the nearby abdominal wall to the peritoneum. This is more characteristic of stage 3 ovarian cancer, which is why we settled on this combination stage diagnosis for the patient. Additionally, treatment is going to be the same for both of these conditions, and it would not change our management either way. This is a particularly notable condition because it is an incredibly rare form of cancer. Approximately 3% of all ovarian cancers are mucinous carcinomas. They have a completely unique histology, and it is incredibly important to rule out GI cancer, both concurrent as well as making sure that that's not actually the primary malignancy that the patient is suffering from. Historically, the similarities between mucinous ovarian cancer and cancers of other mucin-producing cells have made it incredibly difficult to differentiate between the two. As such, this patient will be scheduled for an EGD outpatient and is interested in pursuing systemic chemotherapy as well as immunologic therapy, and will be starting treatment very soon at a center closer to her home so she can be surrounded by her support system while she goes through this process. Thank you for listening, everyone. I hope you have a good day.